Fantastic. Now, I know that you have some personal interest in these studies. Are you
Yeah.
willing to share and tell us about that? And is this why you chose concussion specifically as a topic to research in sport?
Yeah, I would say it is a personal thing for me. I would say running injury probably is another personal thing for me as well. But the head injury research really, my interest in that grew from my own experience of playing rugby. So I was quite a high level rugby player, played for the university, for our local counties as well. And when I was young, I suffered my own head injury, um, and it didn't, I would say, prevent me from playing ever again. But it was one of those things where when you get a head injury, you consider your options after that and whether it's the right thing that you want to carry on playing or not. So for me, the difficulty was at the time I wasn't a physical therapist, so I wasn't aware of all the assessments and things like that. But I was young and I had a head injury and I'd actually fractured my frontal plate of my skull during a rugby match. I wasn't unconscious, but I did have some double vision and I had a dent in my forehead. And for me, then getting assessed by the physical therapist at this pitch side, who was concerned, obviously, because I had this dent and I was dazed, and they sent me off to the hospital to kind of get assessed by somebody in the accident and emergency department. And I got assessed after after probably an hour or two of waiting in the emergency room department. And I was assessed by a nurse practitioner at first who said, "Oh, I couldn't possibly have fractured my head skull, and I looked fine, and that probably didn't have a concussion. I was probably all right." Then I got later assessed by a junior doctor who then um, believed that they may be a fracture, so I went to get some
Hmm.
X-ray forms. But later I was away for probably half an hour to an hour and came back and said, "Oh well, a senior doctor's told me that rugby players, when they get head injuries, it just swells up around the site and then it goes away after a week or so." So sent me home with a little bit of card that has some rules on around concussion, and basically after a week, obviously the dent had never gone away, and I had to go back in and get assessed again. And a senior doctor saw me and almost immediately sent me off to get surgery to kind of get some plates put into the fractured area so that it was stable. Because obviously it's a big risk if you have a particularly a fracture. You
Yes.
could get a subdural hematoma, or you could get something even more problematic. And really, that to me hit home, particularly when I became a physical therapist after that, because it was the year before I took that on. Hit home to me about the difficulties with the assessments, even for medical practitioners who largely probably in an emergency room you're probably not seeing this a
Hmm.
lot.
Correct.
You probably see it more in the sports
Hmm.
world, and then you'll see it in the emergency room. It's probably more severe. You probably get people like myself probably with a fracture, or you might get somebody with a more severe traumatic brain injury. But concussion injuries, you may not even attend an
Correct.
emergency room. You may just see your local practitioner, or you might see somebody at the sports field who just gives you the advice to go and rest for a couple of weeks. And largely, we haven't really moved beyond that either. We still just tell patients to rest for a couple of weeks, or to take it easy, or to gradually increase their activity levels back to normal within reason for their symptoms and things. So it's still a little bit of a grey area, I believe, particularly the assessments though, because they're still very subjective, very clinical experience orientated. And if you're not seeing these things all of the time, you might miss these subtle deficits. And even if you are seeing them all the time, some of the deficits can be so subtle that you might miss them. So some of the evidence really, published evidence actually shows that professional rugby players in the United Kingdom, if they sustain a head injury, a concussion injury within a season, and then go back to play within the same season, they're 60% more likely to either have a second concussion injury or a secondary musculoskeletal injury. So, really, we're talking about people continuously having injuries because we're not sending them back appropriately, because we can't pick up on the subtle deficits that really wearable technologies such as the dorsaVi sensors might be able to provide some information on that you wouldn't see with the naked eye.
It's exciting. Thank you, Sam. There's certainly a lot of room for more research and data, and I believe all of us as clinicians see an area that we can improve upon to serve our athletes and our head injury patients better. Did you have one more slide, or was this the last
I think
one?
this is the last slide that's on now. So
So-
the last slide I've got is it's related to running injuries. Actually, another thing that I've had many of over my time. And this one, I've got a PhD student and a master's student working on this project. And this is looking at individuals who have a history of running injuries, or who don't have a history of running related injuries, particularly lower limb injuries is what we're interested in here. And really, that from a clinical point of view, we want to be able to pick up on whether there are subtle differences in running gait patterns with those who potentially have a history of running related lower limb injuries. Because if you can pick up on that when someone potentially comes into the clinic, you can really kind of hone in on what subtle changes in their running movement have occurred as a result of their injuries. And then we could potentially give some interventions around that. Because certain injuries, you might recover, but you might not fully recover certain aspects of your movement, your speed, and things like that. And really what we're looking at, particularly in this one, metrics we're interested in are particularly the symmetry, but also some of those other elements, particularly symmetry, I would say, and the peak acceleration movements as well. But we're comparing this to what a clinician would normally do. So a clinician normally, if we're doing a running gait assessment, we might video an individual running on a treadmill for a period of time. And then we might do that at either set speeds, or we might give them self-selected speeds. And we'd video them from different angles to try and pick up on different movement patterns, and then use visual observation basically to see, is there a difference? We're also doing specific video analysis around that. We're using a freely available software called Canovia for that, where we can look at the different angles of joints, and we can look at the different movement patterns that people might have. We're also doing visual observation outside as well. We get people to run around a track for 20 minutes while, again, another physiotherapist watches them do that on the different elements of the track. But the dorsaVi sensors are being used for this project to basically give us these metrics around their running gait to see if we can pick up on these subtle deficits. Because ultimately, I believe that we'll probably find that, because we've done the same with walking assessments in the past, and we found that clinician observation can't pick up on some of the very subtle changes that occur with some of these problems. So whether you have a neurological condition like concussion, or whether you have more of a musculoskeletal orthopedic issue, such as a lower limb injury here, you might get subtle changes to the way that you move that relate to those previous impairments. And then these sensors potentially can pick up on the subtleties of those deficits, and then provide us as clinicians with targets for rehabilitation. Because the problem we face, obviously, as physical therapists, is that we want to give very individualized and tailored rehabilitation. But part of the issue is that sometimes you might get somebody in who looks like they've got a similar condition to somebody else, or a similar problem to somebody else. So you give them basically the same rehabilitation exercises, or very similar. Or you might just not be able to see what the problems are, and you give them a very generic kind of program around potentially strengthening or potentially movement activities. But this would allow us to really target those areas, and to see what rehabilitation techniques can specifically get at those metrics that are problematic for these individuals. Now, a lot of clinicians probably, when they're looking at running gait, would probably say they can probably spot whether someone is asymmetrical or not. So that to me, show a lot of people that I've talked to, particularly sports physicians and physical therapists, would say that they could probably spot that. But for me, we're talking about subtleties that could be a few degrees. They're not huge differences. It's not like we're testing stroke participants that have huge deficits on one side. We're testing people who are generally fit, healthy athletes in this sense, and they can compensate quite well for things. But it's whether they can compensate for those things over a 20-minute period or a 5-minute period, or whether those very subtle deficits across an average of somebody's gait pattern across that time are actually visible. Because I know myself, when particularly looking at someone on a treadmill, even though they're on a treadmill and they're in a static position and I can move around them, it's actually quite difficult to spot a lot of these problems. Even when you video it and you kind of try and slow it down, it can be difficult because of you just can't get the angles that you need to be able to view these things either. And I do a lot of the other thing I do a lot of is vision research, and I know for a fact that human vision works within probably about a 30 hertz range. So these sensors are a lot more high frequency than that, and they will pick up on things that we really can't see because we just don't have the frame rate to be able to actually pick up on those problems. So this study in particular, we're looking at 40 university athletes. We're using runners for this one. We're looking at 20 with and 20 without history, and we'll compare all of these different metrics from the dorsaVi system. We also do, like I say, the video analysis, and we have qualified physical therapists who are looking at these videos as well as watching individuals on the treadmill at the time to see if they can pick up on any of these problems. And then we'll compare those measures and compare what the clinician says to what the sensors say to see if we can spot any differentiation between the two. And we're, again, using all of the measures, but we have some key ones we've picked out, particularly the accelerations, velocities kind of thing that the initial peak provides us with. Ground contact time is another one we're looking at, again, because it's one of the most commonly used in running gait analysis. But we are using the range of measures and then seeing if any of those are different in these different groups.